Hello, everyone, and welcome back to our next interview. Again, we are celebrating a virtual open house today of our new clinic located at 3322 East Main. And for those of you who've been asking, we're not moving. We're going to keep our area on the west side, but we are moving and opening up on the east side of town. We will be open on March 1st. I know we've had to push this back, but all of our equipment that's coming is stuck in Houston, Texas. So obviously that's a real problem. And the only thing I really need here is tables. And those are all stuck in Houston, Texas. So we joked about that as well. So remember, if you're getting involved in our contests and our prizes that we're going to give out later today, make sure that you go to the web link that's on our Facebook page to get signed up. You can also like, share, comment on our videos, and that will get you signed up as well. Tons of prizes here to give away. I'm going to run down our sponsors for today real quick. Sunshine Cafe, O'Reilly's Auto Parts, Mattress Firm, Sherwin-Williams, American Rental, Nature's Nook, Bob Evans, O'Charlie's, BW3s, 40 Bowl, Johnson Chiropractic, Studebaker Buick, Lux Lizzie's, Olive Garden, Chili's, Jimmy John's, Texas Roadhouse, Journey Yoga Studios, Therapeutic Solutions, and El Rodeo Restaurant. So please make sure that you visit those folks because they've been great. We're going to move right into our next guest. I'm very pleased to welcome Dr. Wes Lackey, who is an orthopedic joint replacement surgeon at Midwest Center for Joint Replacement. So let's bring him into the conversation here.
Hello.
Hey, how are you?
Great. How are you doing?
I'm doing great. Thanks so much for joining us today. We're really happy to have you here.
Thank you.
Let's just for my people who are watching. I call it my people, but my people who are watching today, can you just tell us a little bit about yourself and your connection to Indiana and what you do and where your practice is located and what your specialties are in?
Yeah, so my name is Wes Lackey, and I grew up in Evansville, and I was here in Indianapolis for medical school. And we have just 2 days ago celebrated 6 years of Midwest Center for Joint Replacement. We felt that we could, similar to Cutting Edge, that we could make our care more streamlined, more efficient, and more patient-centric. And so we broke off and started our own thing 6 years ago. It's been wonderful. We've been leaders in outpatient joint replacement space, which has been great for us and for our patients, especially serendipitously during the COVID year. That's been a great thing to keep patients out of the hospital for the most part. We have an office, our main office and headquarters, and our surgery center are on the southwest corner of Indianapolis, just south of the airport, across the street from Decatur High School, if you know where that is. And we have a new office that opened just under 1 year ago, just in time to shut down for COVID, in Bloomington at 2nd and Landmark.
Great. So tell us a little bit about it. It's not just you. There's multiple other surgeons that you are partnered with. So tell us the other surgeons that you work with.
Yeah, so there's 3 main partners in MCJR. One is Mike Barrand, and the other is Josh Carter. And we are all hip and knee replacement specialists almost exclusively. We do have a couple other colleagues that work with us. One is Todd Bertrand, who is an orthopedic oncologist, and one is Sebastian Piers, who's part of Reconstructive Hand to Shoulder, does our upper extremity work at our main office in Indy.
So obviously, when I started practicing 25 years ago, there were orthopedic doctors who were doing, I'm going to do your carpal tunnel, and then the next hour we're going to do your back fusion. And that has certainly gone by the wayside at this point, hasn't it?
For sure. The number of generalists has declined over the last couple decades, and the number of fellowship-trained specialist surgeons has greatly increased. There's great data that shows that high volume is an indicator, both the high volume of the surgeon and high volume of the institution both matter for improved outcomes for patients, such as lower infection rate, lower complication rate, better patient satisfaction, forgotten knee score, that kind of stuff has been better for specialists. And there's certainly enough work to go around for us to keep busy.
I've sent patients to you. You've sent patients to me in the past. What should a patient look for when they need, say, joint replacement? What are the right questions they should be asking you, or when they're looking for an orthopedic doctor?
Yeah, lots of things in there to talk about. When it's time for surgery, we always talk about, hey, the patient tells us, not us telling the patient. In terms of joint replacement is an outstanding option if you need it. And patients always say, well, how do I know if I need it? And we always say, you'll know. Meaning, it's one thing to have, yeah, my right knee's always kind of bugged me, but I still do everything I want to do. It's another thing to be missing out on life events, missing out on travel, missing out on sleep, missing out on playing with the grandkids, those kind of things. And that's when it's time for surgery. How to select a surgeon for a hip or knee replacement is easy. Just give us a call at MCJR. Okay. But honestly, we do have years ago when we looked at it as a group, the average patient traveled 80 miles to come see us. That's been some time ago, but a lot of the southern half of the state, particularly, and then a lot of people come over from Illinois to see us. A lot of people from the east side of Indiana, from your all's region, come to see us down from Kokomo, that kind of stuff. And so we do take care of a number of people from our state and surrounding states. And that's our thing is we do one thing and we do it well, and that's joint replacement and nothing else.
And I can attest for that because I see the people on the other end. I see the patients and how well they do and how well they're taken care of. What's so unique, other than the fact that you guys do a lot of joint replacements? What are some other options for people when they come in and they have pain that you go through first before we get to that end all be all where someone needs a knee replacement?
Yeah, we always tell the patients there's nothing better that we can offer you than motion. We always tell them motion is lotion. Keep it moving, keep it active, maintain your strength, maintain your functionality, maintain your range of motion. I always tell patients that it's very common when someone comes in to sign up for a knee replacement that they've been dealing with it for 10 or 20 years, including anti-inflammatory medicines, exercises, therapy, injections in the joint, that kind of stuff. And finally, they're sick of it and then they get a knee replacement. It's very common that hip patients go from no symptoms to surgery in less than a year. Hips are constrained, they wear out faster. And we don't often do steroid injections in hip joints because it just doesn't work. A lot of patients will say, yeah, it really felt better. Well, for 3 days, we say, hey, that's not worth it. Feeling good for 3 days. That doesn't help you in the grand scheme of things. What's the 30-year plan? Let's talk about that. And the big thing for that for us is that, we hear all the time, I was told a hip or knee replacement lasts 10 years, and that hasn't been true in 30 years. Yeah. The materials are that good. And so buying yourself an extra 6 months of pain and agony is not worth it. But yeah, so back to short of surgery, we do shots all the time. We have a number of patients that we'll just kind of swing by any day of the week because we've got people in the office and anyone can do it to pop an injection in the knee if and when they need it. And we always tell them if hey, we pop this shot in and you have a great 6 months and life's doing well, then keep it a go. We'll keep doing this. And sometimes we do it for years. And then when it's often that, yeah, it used to work for a year at a time and then 6 months and then 6 weeks. And the last one didn't work at all. And I'm sick of this.
Gotcha. Now, I've had patients come from you, and let's talk about Midwest Center for Joint Replacement because we observed surgery with you. It was just such a great process. Can you talk about patient-centered care and what makes you guys so great at what you do? And I was just overly impressed. And that's just not me saying it, but I have patients who come and say, this was an awesome experience from start to finish. So tell me a little about you know what I mean? Philosophy about how you guys handle patients.
Yeah. Basically, when we started with a blank the blank whiteboard of what do we want MCJR to be when we were starting from scratch. And we knew that going from big institutional hospital coming and taking over the program and making it kind of standardizing mediocrity with other programs, we said, hey, we want to make this unique. And so what are the things that we think about? When I go to the doctor and they slide the glass window over and tell me to sign in, even though they're just going to then look at that and take my name down instead of just talking to me, hey, we don't want to do that. So we started with our office and making it just different and more open and more inviting. And we had to shut down our coffee bar with COVID. But before that, people would come 2 hours early with their friends and just sit and drink coffee in the lobby and charge their phone and use the Wi-Fi and do whatever.
That's such an awesome story, though. Isn't that great to have people want to come and just hang out?
And some would start even coming on their non-appointment days just to hang out. And so on our business cards, all of our surgeons' cell phones and emails are on those. Those go out to everybody, to whether it's therapists or the patients or referring docs or anything. Our cell phones are out there, and everybody wants to know if people abuse it, and they really don't. They actually underutilize it, I think. They still call us through the answering service. So our why statement of MCJR has been taking the pain out of joint replacement. And that includes for the surgeons and for our staff, but it's especially the patients. And that doesn't mean just better pain control, which has been a dramatic, better pain control has been a dramatic change in the last 10 years, which has led to outpatient joint replacement. And I tell people all the time, hey, I'm going to make you sore, but I'm not going to make you sick. And so we don't need to put you in the hospital with sick people. And so taking the pain out means you've got my cell phone number if you need me. It means a human answers the phone every time, never a computer voice tree thing. It means quicker recovery time. It means quicker back to work times. Our average return to work for all comers is 6 weeks. And that's significantly shorter than kind of standard published data from bigger institutions. Lower infection rates, that kind of stuff. Plus, not to mention most common insurance type in the state is through Anthem, but it's not paid through Anthem. It's paid by the employers. And so the businesses and the people of Indiana save a third on the cost when they have surgery with us. They pay 50% more when it's the same operations done at the hospital.
Wow. That's just striking right there. Hey, I'm going to jump in here because we got a couple of questions, so maybe you and I can help answer those together. So let's pull this first one up here. This is from Teresa, who said, I just had a complete knee replacement surgery just 10 weeks ago. Can you give me any tips on more strength and endurance at home? From my standpoint, I'll let you jump in here, but I'll kind of jump in here. Well, first of all, Teresa, if you're just 10 weeks ago, you should certainly still be doing your home exercise program that your therapist guided you in doing. And that should be a daily thing. I tell patients you should be doing this for at least 6 months, because we know that the improvement time frame is over that usually 6-month period. So that's one thing. But the other thing is you can come back in, make an appointment with us, and get a tune-up, because you might be doing some exercises that are too easy, and it's time to get a tune-up and go further. Doc, what else do you think about that?
Yeah, that's great. I love that you said 6 months. Patients ask us all the time, tell me what the recovery is going to be like. And I tell them I can give you averages, but I can't tell you because everybody's different. We do the same operation 2,000 times a year, and one person tells me, it didn't even hurt. I never took a pain pill. And another person tells me, oh my gosh, I thought I was going to die for 3 weeks. And so everybody's different. It's definitely a cooperation between surgeon and then once we're a little bit out, we're always available, but we're a little out of the picture after we've done put it in, and if we put the parts in right, then it's the relationship between patient and therapist to get you moving and get you going. And everybody's needs are different. Everybody's desires are different. Everybody's activity levels are different. We always tell patients, you're not going to be done healing for 6 months.
Yeah. And what I think is so great is the fact that we can call you, or I can just say, hey, I'm not sure, but I know you have his phone number. So why don't we call and ask? There's people, I think, I agree with you, that they're always worried about bothering us, but that's why we're here. I mean, we're doing a job here for them, and we're seeing them through this 6-month process. That's why we're here. So come back in, see us, call us. It's no trouble.
Absolutely.
She had another question. So I just had complete knee replacement surgery 10 weeks ago. I'm sorry, wrong one. My bad. Let's get this one in. I had one done last year and this one didn't seem to do as good. I hear this all the time. Oh my gosh, my left one was phenomenal. And then my right one was different. What do you say to those folks?
Yeah, that can be different factors. Most commonly when people have two, they say the second one was harder. And part of that is if they had arthritis in both knees, both hips, they're comparing the recovery to a bad joint as opposed to now it's good and it doesn't hurt. Also, we fortunately tend to remember the good and forget the bad. Once things are good, then we forget the bad, which is, I'm thankful for that. Now, that being said, there can be a lot of different factors, tons of factors that would make one different than the other. Just as I said, pain is different patient to patient. Recovery time is different patient to patient. I tell people all the time, we do one knee and it looks like it never had surgery. And then we do another knee and they're black and blue from hip to toes. And that also will sometimes, for whatever reason, happen even within the same patient. How come this one was so much easier? What'd you do different? Nothing. And yeah.
Exactly the same. And it's hard for patients to understand. But I just say, hey, every surgery, they're doing the same thing, but your body reacts differently every time. So that that happens. Let's see. We got another question here. I always wonder why we had to sign ourselves in when we immediately take the clipboard and start checking us in. I like the one-on-one communication rather than that way. I mean, I think there's something special about what you guys do at your place. I try to replicate very similar things where we're just being very interactive with the patient. I will tell you that sign-in lists are important for some reasons. And I remember specifically with a patient saying, oh, I wasn't here that day. Well, we pulled out the sign-out list and, well, you were here unless that's not your signature. So there's certainly a reason for that. Let's take a step back for just a second. And most people don't understand the rigors of the training that an orthopedic doctor goes through. Can you tell us a little bit about, you finished medical school for 4 years. What is the training like then to really become a surgeon that's board certified and can continue practicing independently?
Yeah, it's a little bit of a long road, and I'll actually, just for public interest, back up a little bit on that. So growing up in Evansville, I went to Harrison High School, then I went to college, and knowing that I wanted to pursue medicine, my dad was an OBGYN. He delivered 8,000 babies in his career. I always thought medicine was great, and I honestly didn't know a lot about other career paths growing up just because that's what I was born around or grew up around. So I knew I wanted to do medicine, but I also was played the violin, as did my two sisters from since I was a toddler, really. And so while doing the pre-med requirements to be allowed to apply to med school, I was actually a violin major in the music school. Violin performance was my undergrad degree while I was doing, the organic chemistry requirements and taking the MCAT and all that junk. So then I came back up to Indy for med school. That's 4 years after 4 years undergrad. And then I went to residency. Residency applications are fun because you go around and interview, and I drove 10,000 miles in 2 months and interviewed at all these places. And then you rank where you'd like to go. And then they rank what candidates they'd like. And then on usually right around St. Patrick's Day, all the med students in the country, graduating med students, get an envelope that says where you're going to live for the next 3 to 5 years. So I did my residency training for 5 years in Greenville, South Carolina. Beautiful place, growing city, just amazing people. It was wonderful. And then I came back to Indy to do a fellowship with Mike Barron, who I had known as a mentor through our church, which is 3 blocks away from us right now. And did a fellowship in Mooresville with Mike and his partners at the time. And also at the time already knew that I was after fellowship going to join the practice there in Mooresville, but also secretly, it's been long enough that I can say this out loud now, secretly already knew that in 2015, we were going to leave and start our own thing when a contract ran up. And so it's been fun and fast to think that we're already 6 years in.
So,
so I got my first job when I was 31.
31. So, orthopedic, most surgeons in general are going through this kind of training, putting basically your life on hold for all this time frame to do what you do.
Yeah, totally worth it.
Totally worth it. I agree. I think this is some great stuff. I'm looking at my cheat sheet here and what I wanted to ask you. One thing I found, the website is mcjr.com, right?
Yes, sir.
Okay, so I'll put that in my comments here. So if people want to contact you, they can get through the website and get an appointment with you. What I found interesting on your website was that you had 124 Google reviews, and it was 4.9 stars on average. That's pretty hard. Why do you think that is?
Well, interestingly, we've been using a website kind of helper company called Patient Pop to help us get more reviews. Now that it's interesting. We realize that the more, as you have, I'm sure, the importance of the internet searches and the reviews and that kind of stuff. I think the reviews are patients that are happy and have been treated well. We see a ton of people that have been seen elsewhere and then come to us when it's time for surgery, or unfortunately, we do a fair number of revision surgeries as well. But for a long time, it's 90% of our referral base or 90+% has been either patient-to-patient word of mouth, or with relationships with like-minded individuals in the community, like you guys. If you need something, text me and we'll get them in this week. And that's how we've always done business. We've been trying to work on our web presence and that kind of stuff, and getting more people. And so when patients say, I'm so thankful for what you've done, what can we do? I'm like, hey, you can get online and type a Google, do a review. And so
we talk about that every day in the practice. That's for sure. That's fantastic. Let's go back to something that you said. I feel like the press secretary. We're going to circle around now.
Circle back.
Sorry, I didn't mean to bring the politics in it, but going back to something that you mentioned about doing a lot of revisions. We talked. I don't know why anybody said joint replacements last 10 years, because I'm seeing joint replacements from 30 years ago. So it's not, but when does somebody know that they need a revision of their joint replacement?
Yeah. It reminded me back when one of our listeners asked about, hey, I'm 10 weeks out. What do I do? It's different than last time. There's a big difference, and sometimes it's just a kind of sense thing. There's a big difference in, it's not quite as, whatever. It's a little stiff, or a lot of times it feels stiff for 6 months, even if the range of motion is perfect. So there's a difference in, hey, how come this took me 10 weeks instead of 6 weeks this time? Or there's a difference there than, hey, it's been 6 months and it's not right. Something's wrong. That's a difference that you just kind of have to feel out with patients. And yeah, of all the reasons we revise implants, it wearing out like tread on your car tire over the years and you need a new tire in your implant is zero. We just don't do it. We see instability, hip dislocations, we see loose implants, we see tons of infections, and those get sent to us from all over the place just because we're the kind of the specialists in the last stop shop a little bit. So how do you know? Well, sometimes you don't. Sometimes it's obvious and sometimes you don't. And that's it. And there's some easy things that we can do. Anytime someone says, hey, look, my implant's not right, we're going to test them for infection, because it's one thing if it's red and there's pus draining out of it. Is another thing of people that just like, it just hasn't felt right for 5 years. And then we find out that there's kind of been a real quiet infection brewing in there all along. So we do that. And then we also use diagnostic injections a lot of times. What's that? That's taking a big slug of lidocaine, like numbing medicine, and filling up the joint with that. And that can tell us a lot. Sometimes on the x-ray, the knee is totally collapsed or crooked or put in wrong, and it's totally obvious, but a lot of times it kind of looks okay. And the patients will often say, yeah, my surgeon or whoever, I've seen multiple doctors or whoever have all said, yeah, it looks fine, but sometimes we can detect other things going on, like subtly loose implants, different things like that going on. So a lot of complex stuff, and every patient's unique, and we take it one step at a time, but we kind of have an algorithm for how we approach the painful implant.
Gotcha. What is the percentage of people who have joint replacement and then have to come back because something's just not quite right, whether or not it got loose or something broke or had a patellar fracture, or it's very small, is it not?
It is small. It depends on how you categorize the failures, and that there's movements to do national registries. The problem is those only capture when the implant comes out. That doesn't capture, I don't like it and I never liked it, or I got stiff and it's just really not that functional, or I still had to give up those kind of things. And so the subtle things, there's a lot of things that could go wrong, but they can be fixed. And so that's the key, is diagnosis and fixing the problem. And so what I always tell patients is, oh, well, what we care about is not like, oh, did you use your cane for 2 weeks or 2.5 weeks? We care about what was the 30-year outcome. And so what we look at is a 20-year survivorship for hips, knees, and partial knees at this time is hovers up and down around 90%. So what's the chance that you have one operation, you don't need a second operation, and at 20 years you come by for a high five and you're still great? Is 9 out of 10 or more.
That's pretty significant. And this is pretty close to me because more recently we had a patient come in who never did well. The something wasn't right. And I could tell something wasn't right. We're kind of often put in the middle of surgeon saying everything's right and the patient going, nothing's right. And I'm thinking it's not right. So we sent you a patient because he wanted another opinion. And so I said, hey, go see Dr. Lackey. I know him. He'll take good care of you. If something's wrong, then something's wrong. If he'll say, hey, it's perfect, I think you need to work harder, or whatever it happens to be. And the first thing he did was, when he came back, he says, oh yeah, Dr. Lackey said it's rotated or it's not right. We saw it on the x-ray. This was a guy only getting 60, 70 degrees of flexion, So we do see it. And the great thing about your group is that we can just coordinate. It's a phone call. It's a text. It's just easy. So that's why I really encourage people to come see him.
Yeah. Also, as much as we love to operate, we also love to not operate. I've seen a ton of young people that, if the joint is destroyed and you're young, it's the right thing to do to get a knee replacement or a hip replacement. But we see a ton of people like, hey, I came for a second opinion. They were going to do the laser experimental surgery injection thing, not approved, and I'm like, hey, you just need a good therapist. And so it's great to know people like you.
Thanks. I appreciate that. Is there anything else that, we're kind of running up against the time here that I wanted to be respectful of your time. What is there certain things that patients or the folks watching should really know about your group or you personally, and how you handle cases, and anything maybe new from an orthopedic standard that's kind of coming out that might be, hey, this is cutting edge. We're kind of on the line of this. What do you think?
Yeah, what I would want people to know is just we're normal people, and we've got a fantastic team of people at our office in our surgery center, and you'll get to see them all if you come visit us. And anyone's welcome anytime. I don't know how many therapists we have on here, but we have a ton of therapists that we know that have taken care of knee replacement patients for 20 years and have never seen a knee replacement. So we say, hey, come watch surgery. Let's go. What day do you want to come? We're there working. In terms of what's the latest, I would say the big keys are again, taking the pain out of joint replacement in terms of outpatient surgery, anterior approach to the hip, which is a hip replacement is to put in hip replacement parts, but there's different ways to get in and get out. And getting in from the front and out is a much easier way for the patient to experience a hip replacement and great function and great outcomes. Not everyone's a candidate for that based on weight, bone quality, different stuff like that, but most are. And then a big thing for us at MCJR that makes us actually pretty unique is partial knee replacement. We divide the knee up into 3 compartments, medial, lateral, and the kneecap compartment. And a lot of people, almost 50%, only wear out in one of those compartments when they wear out. And so what we say is, hey, joint replacement's great. It's better than bone on bone, but it's not better than what God gave you in there. Why don't we just address the diseased portion of the knee? And so the number one question we get, which is what I would ask too, is, wait a minute, if you go in there and you only do part of it, aren't you going to have to come back later and do the rest of it? And that is a great question, but that's not the case. If that were the plan, we would never do it a single time. That's not worth it. We want one surgery forever. And so it is a permanent surgery. So it can happen that a knee wears out the other side and we have to redo it, but it can also happen that a total knee has a problem and has to have another surgery or gets stiff and needs manipulation, different things. And so what we'd say is that the risks of a partial knee are 1/3 that of a total knee in terms of surgery, heart, lungs, kidneys, infection, and blood clots. The risks are cut down to 1/3, and the durability is the same out to 20 plus years. And it feels more natural on your body because we left more of your normal anatomy there. So that's a key for us of taking the pain out of joint replacement by doing less surgery. That's, a true minimally invasive surgery is to do less bone removal.
Yeah, and that's a great point because and people don't realize the recovery time for those partials. I mean, you're talking 3-4 weeks, and these people are great. I mean, they're moving great, and if you only need that partial, that's what you should get because your recovery time frame is so much quicker. You're back up on your feet, you're back to work, all those kind of things. Yeah. One of the other things I found unique about you all is, excuse me, is that people go home. People have their joint replacement and go home. And you and I talked about that, and you said, well, if you're going to be miserable for a couple of days, we'd all rather be miserable at home than miserable in the hospital.
Yeah. That when we started our outpatient surgery center, outpatient by definition of the payers and stuff is 23-hour observation. So we made it ready for everybody to stay the night. And even in our first year, 7 years ago, at the surgery center, only 1% stayed. And in the first year, the most common diagnosis, appropriate timing, the most common reason for staying overnight was snowstorm and urinary retention after that in men with bad prostates. But now we're to a point where 90% of our patients are done in our outpatient surgery center and go home. It's still about 1 or 2% that stay overnight. And we always tell anybody can stay that needs to, anytime. We're ready. Anytime you can stay, but no one ever does because why would you want to? And I would push back a little bit. I'd say, yep, there's pain. It's going to be sore. And it's different for everybody of how bad that is, but I wouldn't say be miserable at home. Most patients, it's very rare that a patient's truly miserable at home. And we've actually never needed to admit a patient to the hospital for pain control.
But that tells us that you guys are doing a great job of keeping people's pain under control right after surgery. Yeah. Dr. Wes Lackey, I appreciate your time. It's good to see you, and thankful that you came on with us. I think a lot of great information, a lot of great comments today, and I do appreciate your time.
Hey, my pleasure. Congrats on the new office. Hope to see everybody in person sometime, and take care.
That'd be great. Thank you. So another great interview, Dr. Wes Lackey, really great orthopedic surgeon at Midwest Center for Joint Replacement, mcjr.com. You can find all those folks. And as I said, I highly recommend that group. They're excellent at what they do. Again, we'll see you. I have another interview ready for 3 o'clock today, and that is on women's health and women's health physical therapy. It was a replay from last night, and we'll see you soon.